My case is a 29-year-old married female residing at Meerut and chartered accountant by profession. Presented with chief complaints of lower limb swelling on and off since 6 months and shortness of breath since 10 to 15 days. In ODP, she was apparently well 6 months back when she started noticing lower limb swelling, which was up to the ankle, persisting few hours in a day, more on dependent position and disappearing on elevation of the lower limb. This pattern continued till 15 days before the presentation, and in last since last 15 days, his her lower limb swelling was persistent throughout the day and is progressively increased up to the knee. Uh, and since last 10 days before the presentation, she also started complaining shortness of breath after a heavy exertion on the floor, but she was able to do her household work easily. And this shortness of breath was not accompanied by any cough, chest pain, syncope, or palpitations. So for these two complaints, she consulted with her local physicians and underwent routine investigations. At that time, she was found to have hypertension with blood pressure of 150 by 90 and started on medications for the same. And during this evaluation, she also told to having some fluids in the lung. And for her lower limb swelling, she was started on medications that eventually increased her urine output. And her shortness of breath was symptomatically improved, and leg swelling also improved after that medicine, though she did not remember the name of the medicine. And she was also told that she is leaking protein in her urine, and she was referred to nephrologist for further management. So she presented to us with these complaints and investigations. Uh, After admission, she underwent native kidney biopsy on 20th of October, which was uneventful in post biopsy period. In past history, she is not diabetic, not hypertensive, no past history of any tuberculosis, chronic illness, or any major surgery, no history of any intake of allopathic or alternative medicines. Family history was not significant. In personal history, she is married 8 months back. Bowel bladder habits are normal. Sleep was adequate. She is consuming vegetarian diet and no history of addiction. And menstrual history is regular for every 28 to 30 days and no complaints of menorrhagia. And she on negative history, she did not have any history of rash, fever, joint pain, any chest pain or cough, no history of hair loss or mouth ulcers, no history of alternative medications. So at the end of the history, I would like to summarize. 29-year-old female presented us with lower limb swelling since 6 months and shortness of breath since 15 days. Um, so syndromic diagnosis would be nephrotic syndrome, and I would like to give differentials: uh, FSGS, IgA nephropathy, lupus nephritis, and membranous nephropathy.
FSGS.
IgA nephropathy, lupus nephritis, and membranous nephropathy.
So just based on your history so far, how did you put a prelim diagnosis of nephrotic syndrome on this patient?
So he had gradual.
Can you hear us? Is it audible?
Gradual onset and progressively increasing pedal edema, and since last 15 days, she was also started having shortness of breath, and she was told to have some fluids in the lungs, so maybe a pleural effusion with pedal edema, so it's likely that she is having edema plus hypoalbuminemia. So I would like to keep nephrotic. There is no history of hematuria. And
from the description you give, that sounds more like just a fluid overload state. What specifically? I know you're a nephrologist and we are talking about nephrotic syndrome today. But what
Uh,
specifically made you put that prelim diagnosis on there?
On routine evaluation, also she was told that she is leaking protein in the urine, and that was significant. Though she did not exactly remember the value, but it was significant, and then she referred to nephrologist for further management.
Proceed on with the basic labs and exam.
So in general examination, her height is 150 centimeters with weight of
No,
40.
but you've talked about nephrotic syndrome. Would you want to keep any other possibility at this stage? You see, it'll be like organ specific. You're talking about kidney. You are not talking about heart as the cause of this constellation. You're not talking about liver as the cause, or the lungs, or lungs as the cause, because there was edema, there was dyspnea. All right, so you will have to convincingly exclude heart and the lungs as the cause of this thing. By merely saying that proteinuria could be an incidental finding, that may not have been. A person could well have a proteinuria 1 plus, 2 plus, yet not nephrotic syndrome, because the history will not tell you that this is nephrotic syndrome. This is organ specific. Okay, that's like, okay, unnecessarily putting you any difficulty.
I had asked for any associated cardiac or respiratory symptoms in the form of fever and cough, pleuritic pain for respiratory part, and for palpitations, syncope, and chest pain.
चलो वो तो एक हो गया, हार्ट एंड किडनी को रूल आउट कर लिया आपने, बट हाउ within the framework of the kidneys you have kept only one possibility, and that's nephrotic, period. You and then you have enumerated the various possibilities, the various pathological diagnoses. So syndromic diagnosis, are you happy keeping just nephrotic syndrome as the this thing, or could it be something else as well? You yourself have said the patient had edema which can go with nephrotic syndrome, dyspnea which can go with nephrotic syndrome, blood pressure, all right, high blood pressure, hypertension. Now I'll take you to the other side of the story. What is against this being a nephrotic illness?
Can still a possibility because he had a hypertension, but it was detected late just on a routine evaluation while she presented to physician, and that too.
Maybe it was not checked earlier. Even if you had checked her blood pressure 2 months ago, it may still have been on the higher side. So you'll have to defend now. Now you made a diagnosis, you had all the time on your side, and you have to tell us that no, I am not keeping a possibility of nephrotic illness. When you say nephrotic, obviously as a nephrologist, we have some specific etiologies in mind.
The nephrotic syndrome generally worsens very fast. It not to be indolent for 6 months. Then there will maybe history of hematuria, fluid overload, oliguria.
वो तो है इसमें भी
There is no history of oliguria.
है, आपने डायूरेटिक्स दिए तो ठीक हुई ना?
So there, she did not notice
Okay.
any reduced urine output,
Okay.
but for lower limb swelling and for lung fluid, she
So
was
when you
given.
say a nephrotic illness, what comes to your mind? I'm not talking about nephrotic illness. What you are referring to is a classical nephrotic illness, whereby you will have oliguria, you have hypertension, you have you may have hematuria, you may have this. That's a classical acute glomerulonephritis, right? And the other spectrum is nephrotic, which is what you are describing. There's some mixture of these two. And when we say nephrotic illness, some specific etiologies come to mind. Can anyone let us know about what will you think of starting from this side? MPGN. So if I say that this has been MPGN, now MPGN is, we'll have to start using the contemporary nomenclature. MPGN is a pattern, all right? So MPGN in 2023 is not MPGN what we used to refer to as MPGN 2 decades ago. So, okay, are you saying MPGN type 1? That's one. I mean, you see, we'll have to, from the pattern, we are saying that it's an immune complex, or it's a complement, or it's a. So if it is MPGN type 1, I may ask, or if it is C3 glomerulonephropathy, Can you fit your patient into that?
So for
How will an MPGN type 1 present?
type 1 is mostly associated with either infection or autoimmune.
No. How will it present? I'm saying you said FSGS, IgA, lupus, MPG, membranous. I'm asking you, why are you giving a step fatherly treatment to MPGN? Why not include MPGN type 1 as well in your this thing? Can it be? For the sake, because आपने चार चूज की, आपने कई नहीं चूज की. There has to be some reason as to why you didn't think about the other possibilities. And before we proceed any further, I'm asking you, can it be C3 glomerular nephropathy? It cannot be.
It's not fitting in age.
एज तो बड़ी अच्छी एज है, 29. दो तरह के होते हैं ना C3 nephropathy. So age किसी के अगेंस्ट नहीं जाती, mind you. Age तो typical of course is there are two varieties, the non malignant varieties, and the other one is seen typically in adolescents. It is seen in late second decade, all right, and can go extend up to 29. I won't be surprised, right? And the other age group is 50 when you have it with a part of MGRS, all right. So, and why not MPGN? MPGN type 1, typically 5 to 30 years of age, she fits in that. So I'm not saying that what you have said is wrong. I am only wanting to know whether whatever you have said, it indeed you're. I want to check the clarity of thought before you proceed any further.
We can put it lower down for MPGN and other like amyloidosis, fibrillary glomerulonephritis lower down
So,
as a part of
कुछ भी नहीं छोड़
nephrotic
सकते
syndrome.
ना,
Yes.
you can't. So why specifically?
Because I want to just give 3-4 differences so that I have
I
more.
would objection कुछ और हो रही है, आप समझो बेटा. Objection ये हो रही है, we should at this stage limit ourselves to syndromes. हमने etiology पूछी नहीं. Only if the examiner, if someone, the other person wants to ask you about what goes on your mind, what kind of nephrotic syndrome could it be? I would rather that you come out with, do you believe it's an idiopathic nephrotic syndrome or secondary? That will help me better. Get my point? So when you say nephrotic syndrome, you're right. There is no better explanation than that, right? If you want to, in the same breath, say that, okay, this is my first possibility. I believe that it could be idiopathic membranous, idiopathic nephrotic syndrome. However, at this age, a secondary cause such as lupus in a 29-year-old female, or in India at that age group IgA nephropathy, that of course will be on the primary side, primary IgA हो जाएगा वो भी, cannot be ruled out. So that there is no ambiguity. And the hypertension, you may finish off in the same breath. Hypertension appears to be a part of nephrotic syndrome late, rather than there is no definite clue suggesting a nephrotic illness. You see, the point against nephrotic illness is it doesn't generally change its character. You were right when you said कि 6 महीने से चल रहा था. अगर कोई होता तो उसने शुरू में ही उसको तंग करना था. It doesn't change its character as if कि पहले तो बड़ा चुप करके बैठी हुई थी MPGN and suddenly उसने कुछ हो गया. Unless it had caused such a severe hypoproteinemia that the symptoms became quite but anyway, इसमें कोई नहीं है, as long as your clarity of thought is there, everything is fine. Let's move on now.
So on general examination, height is 150 centimeter with weight of 48 kilograms. So our BMI is 21. Pulse was 78 per minute, regular, and all peripheral pulses well felt. Blood pressure was 132 by 82 in right arm supine position. Respiratory rate was 16 per minute thoracoabdominal, and there was no pallor cyanosis, lymphadenopathy, or a rash or a jaundice. and there's presence of pedal edema up to the ankle, which was pitting in nature. On systemic examination in respiratory system,
Nail changes.
sir, nail was normal. There was no any white lines over the nail.
तो specify करना है, करना है. Hair, character, texture,
Normal, sir, no issue, no any alternate bands or
brittle
elevation,
है या नहीं
no,
है, ठीक है.
no.
Then what else? और skin में कोई pigmentation
Cancel is must for nephrotic
है?
syndrome. No, sir.
तो नहीं है nephrotic में. बाकी और telltale. When you have nephrotic syndrome, तो आपने हर एक nephrotic को सोचना है कि क्या क्या उसकी skin manifestations होती हैं. Before moving on. Skin is skin, bandages, nails, Merkel signs. Then Fabry can be a cause. हो सकता है,
Sir.
ठीक है. Lupus can be a cause. All those causes,
Rash.
ठीक है. All right.
On systemic examination in respiratory system, on inspections, the chest wall was bilateral symmetrical, no any scars or sinus over the chest, but respiratory movement was also decrease in left infrascapular area. And on palpation, this respiratory findings was confirmed, and there was a decreased tactile vocus primitus in left infrascapular area. On percussion, there was dull not present, and on auscultation, there is a decreased air entry in left infrascapular area. In CVS systems, S1 S towards no murmur. In for abdominal examination, soft no ascites, and central nervous system is also within normal limits.
Chest में breath sounds.
So decreased air entry in left infrascapular area. So it's a sign of pleural effusion is present.
Percussion note.
Dull, sir.
ये बताया आपने.
Yes.
Okay.
So at the end of history and examination, I would like to summarize. 29-year-old female presented with pedal edema since 6 months and left pleural effusion with hypertension. Like to keep as nephrotic syndrome with differentials as FSGS, IgA, nephropathy, lupus, nephritis, and membranous.
अभी भी आप idiopathic नहीं बोल रहे. Nephrotic has to
Idiop-
be now classified. I mean, are
Yes.
you dealing with a nephrotic?
On history and examination, I would try to exclude as many as possible secondary cause.
Anything that you thought differently after the physical exam, or you're still thinking on the same lines after history?
No, sir, findings are matching with initial thoughts because there is the presence of edema with effusion.
One of my concerns is, sir, when like you've said it now twice, nephrotic syndrome secondary to FSGS, and then you in the same breath are saying IgA, lupus, and MGN. So I think that is one thought process you should think about. If we have not yet got into the lab values, what did the urine RM show, what is the presentation, how much proteinuria. I'm sure you have a biopsy on board, but when you are saying nephrotic syndrome, then like sir was asking, is it pure nephrotic syndrome or is it nephrotic syndrome? The diagnosis, the differentials you're putting here are kind of mixed for both.
Yes.
So you will have to choose a particular. I know at times it becomes very confusing when you have different examiners, different teachers trying to teach you. Everyone will have his or her own way of reaching to a conclusion. But then I think personally I would believe that all this information should be left for discussion. I mean, we are wanting a syndromic diagnosis, and then you can keep on adding as and when you're asked that what are the possibilities you would want to keep. If you were to do a kidney biopsy or kidney biopsy has since already been done, what do you think will it show in all probability? So that kind of question, and then you can to volunteer for a histological diagnosis. It can at times put you into trouble, and again Same holds true about pausing after your history and wanting to give us information. That's again personal, I would say. I don't want to change your way of presentation, but then there are people who would want to listen to the whole thing, not just at the end of history. Although this has been made a kind of a practice pattern nowadays, then one I may tell you that okay, you keep on giving me all the information, and I'll stop you only towards the end when you have talked about the examination and you reach to your final provisional diagnosis. Provisional diagnosis. Okay, fair enough.
Sir, I have just a question. Can we keep two syndromic diagnosis also?
Two syndromic diagnosis? Why not? You will say this is my first problem. I'll tell you, you will two syndromic diagnosis. The commonest thing for a nephrologist, I believe, it is acute kidney injury. My second possibility is it is acute on underlying chronic kidney disease. There are two diagnoses now. All right. And the third I'll say I may not be able to convincingly rule out a rapidly progressive renal failure. So there's an overlap because it's only we who know that we are wanting to give importance to days and weeks and months, while the history may not, the patient may not be as telling as accurately as what we want to hear from them. Anyway, let's move on and reach to the main reason, the discussion we want to have today around this kind of a case. All right, little louder for this. Yes, you're right. The presentation will be of nephrotic syndrome. But then you will say in the second go, you will have to keep nephrotic syndrome as a possibility. You can say nephrotic syndrome having gone into chronicity cannot be ruled out. I mean, that is one thing which he will be able to say after the examination. If you have pallor, if you have those perforating exfoliative dermatitis, Kyle's disease, you have half and half nail sign. So that you have to keep in now chronicity, bring in chronicity. The pallor, of course, which may not have been, there's no pallor.
No.
So that will be a little odd for. So you have to uh, be convinced. Let's not talk about those cases of chronic kidney disease where there may not be edema or where there may not be anemia. So that will be rare. So we will limit ourselves to when you have different um, uh, syndromic. So it's not very often to keep more than two syndromic diagnoses. Within syndrome, you can keep two or three, four etiological diagnoses and try to defend them. And then you will have to keep one over the other. That I want to keep this, not in this kind of case where you are keeping a possibility of nephrotic. All right.
Uh, in urine examination on dipstick, there is a protein 3 plus, no RBC, there is no cast or any abnormal crystals present.
All right. So at this stage, now we will ask you. You have a patient of proteinuria presenting um, with signs and symptoms of fluid overload and has a bland urinary sediment. All right. So what are your possibilities?
So it sir, mostly rule out nephritic part.
No, nephritic हो गया. Nephritic is not there. There are no RBCs, no RBC casts. You see, because if one has carefully looked into it and there is no microscopic hematuria, you can practically rule out various proliferative glomerulopathies, right? The nephritic syndrome is practically out in the absence of RBCs.
Now I would like to give is idiopathic nephrotic syndrome.
Idiopathic nephrotic syndrome, and which would be your first possibility?
FSGS.
FSGS. Why would you say FSGS?
Sir, because he has indolent course, and also she had on presentation she has hypertension, and for this age nephrotic proteinuria nephrotic syndrome with presence of hypertension. So I would like to keep FSGS higher as compared to lupus or IgA.
In a 29-year-old lady where you're wanting to keep FSGS as the first possibility, what does the literature tell you in terms of commonality? Which is the commonest cause, the pathological diagnosis of nephrotic syndrome in a 29-year-old lady from South Asia?
IgA.
सी जगह की इंपॉर्टेंस है ना. आप इंडिया में बात कर रहे हो, यू विल नॉट कीप बाल्कन नेफ्रोपैथी एज द पॉसिबिलिटी. ठीक है, सो यू विल कीप ओनली व्हाट इज रेलेवेंट टू आवर geographical area. So you will have to know what is the commonest cause of nephrotic syndrome in India, and then North India, and then Delhi, Gurgaon. ऐसे नैरो करो ना. अब आप बताओ मेरे को. And now your literature scanning search will help you. So I have picked up 100 cases of nephrotic syndrome in NCR. And I have read their 29-year-olds, 25 to 30-year-old females, and I scanned their final pathological diagnosis. अब मेरे को आप बता दो, what did I find? The largest series came from All India Institute. कोई है? एम्स वाले नहीं आते ना? I remember the numbers also. 3275 biopsies. 7275 biopsies में ओवर 10 साल की थी, 2005 से 15 या 6 से 16 या 7 से 17. So 10 years data which was published in a good journal. I won't know which journal. The commonest was FSGS. All right. The nephrotic syndrome मैं कह रहा हूँ. FSGS के बाद minimal change. Minimal change के बाद membranous. Membranous के बाद diabetes. Diabetes के बाद lupus. Lupus के बाद amyloid. Amyloid से पहले शायद माइलोमा, पता नहीं माइलोमा. सो एक आया ना मेजर सीरीज. अब अनफॉर्चुनेटली पीजीआई का डाटा नहीं मिला. आई विल बी वेरी इंटरेस्टेड इन टू व्हाट पीजीआई. सो दिस इज रेलेवेंट. हमें क्या लेना देना गोरे क्या कर रहे हैं, हमें तो अपना देखना है. हमारे में क्या होती है, बुखार का कारण हम शिस्टोसोमियासिस ढूंढते हैं, हम डेंगू ढूंढते हैं. हमें अपने घर संवारना है कि हमें गोरों के घर संवारने जाना है. ठीक है ना. So you must know FSGS idiopathic is not. So I'll take you back when I was like you. The commonest cause in adults, membranous nephropathy. 35% membranous nephropathy. 30% minimal change disease. I'm talking about adults. बच्चे तो अभी भी वैसे ही हैं वो. 70 to 90% तो minimal change ही होते हैं. So these figures are important. तब मैं सोचता था ये बूढ़े एग्जामिनर क्या पूछते हैं, उल्टे सीधे सवाल क्यों पूछते हैं. ठीक है, now I understand. पूछते हैं the reason कि आप membranous 35%, 30% minimal change disease, 20 or 18% FSGS. So this was then probably we were missing. IgA मत बोलना. Remember हमने last time भी बोला था, whether you not, IgA nephropathy is the commonest glomerular disease, not the commonest cause of nephrotic syndrome. They are two different things. ठीक है. But quite a few of IgA nephropathies can have nephrotic syndrome, and when they have nephrotic syndrome, it may actually be a good news for the patient, because it may actually be a podocytopathy with incidental steroid. IgA deposits dominant, they respond very well to steroids. Clear यहाँ तक? So commonality, ये बात ज़रूर पता होनी चाहिए कि क्या क्या आपके उसमें आती हैं, right? And अगर हम idiopathic लेते हैं, so it will be, but I will not want you to just go back and say, okay, AIMS will have a bias. उनका patient population different थी. Unfortunately, मैंने अपना analyze नहीं किया. If I were to this thing, I believe सागर बताओ आप, हमें लगता है कि membranous would still be a very common cause of nephrotic in the kind of patient population which we see, maybe little more affluent class in a corporate hospital, right? So we must know कि कौन सा है typical story, associations, hypothyroidism है, very high chances it will turn out to be membranous साथ में, right? Minimal change हो सकता है, but the other thing which you have very wisely not emphasized is it may not be minimal change. This is not the way minimal change disease presents. Minimal change disease will not sit idle for good 6 months and suddenly flare up. So it has been a gradual thing like FSGS finally getting decompensated and getting exposed when the reserve is gone. But FSGS is not the only one which presents like this. Which is the other one? This is what I call clarity of thought. FSGS, he was right and he said बहुत indolent course था and बाद में hypertension भी हो गया. और दूसरी कौन सी बीमारी है ऐसी? मेम्ब्रेनस. मेम्ब्रेनस भी तो ये करता है, वो तो सालों साल पड़ी रहती है, 2 साल 3 साल 4 साल प्रोटीन यूरिया जब भी चेक करोगे. अल्टीमेटली अ स्टेज कम्स व्हेन धीरे धीरे करके हाइपोएल्ब्यूमिनीमिया हो गया एंड एडिमा हो गया. क्लियर? एट दिस स्टेज लेट अस डिफरेंशिएट. वहां से नंबर 2, हाउ डू यू डिफरेंशिएट प्राइमरी फ्रॉम सेकेंडरी, idiopathic from secondary causes of nephrotic syndrome based on the basics, the very basics? Something which I probably used to teach in this forum as well, probably I will stand corrected. This is the statement which I also used to give, that the typical story is primary has a very heavy proteinuria, nephrotic range proteinuria, secondary does not. Now that may not be correct. Both can have nephrotic range proteinuria. The difference does not lie here. Difference lies in the fact that primary causes hypoalbuminemia while secondary may not cause hypoalbuminemia. So that's the crux, that's the key. So you look at the albumin value of a given patient, all right? Barring, there are always going to be exceptions. You can't say that this also happens in amyloidosis. Amyloidosis तो धजिया उड़ा देता है प्रोटीन के albumin सब कुछ होता है. Then these are one. At this stage, let's try to differentiate between. Okay, let's go back and ask you a few questions before the others. What causes hypoalbuminemia in your patients of nephrotic syndrome? Nephrotic syndrome, proteinuria, hypoproteinemia, edema, hyperlipidemia, lipiduria. हो गया? Now the difficult one. Why does hypoalbuminemia occur?
There is a loss of albumin and proteins in the urine, and liver cannot compensate for that loss in the urine.
2 ग्राम 4 ग्राम तो कुछ भी नहीं है लिवर के लिए यार, तो बढ़ा देगा. Sorry? Yes, why? Very good. So it's a tubular destruction of the proteins which destroys the albumin, but your actual quantification is giving you a different story. Only 5-6 grams is coming out in the urine, while maybe 15, 20, 25 grams gets catabolized in the proximal tubules. So that's very important. Liver is trying, no doubt, because liver is trying, and that is why there is hyperlipidemia, because there is stimulation. When liver has been stimulated, it will try to form proteins. It is also getting stimulated to produce lipids. Lipids stay in the body, but the protein is a perpetual destruction at the tubular level, right? So that's what you have to remember. That is the reason why I asked this question. Why should this thing? Then what are the complications of nephrotic syndrome?
Question is increase.
हम इधर से चलेंगे, मैडम, your number. What are the complications of nephrotic syndrome? Sorry? Thrombosis, very nice. Which thrombosis is this? Sorry? TMA? कौन सा thrombosis है ये? Sorry? पूछा ठीक तो बोल रहे, thrombosis इतना अच्छा वर्ड बुलाया, तो आगे बोलो ना. Thrombosis भाई venous और arterial? Venous. Venous कौन सा? Deep के renal? Renal vein thrombosis सुना होता है? वो क्या करता है? Chicken or egg? Renal vein thrombosis causes nephrotic syndrome. Nephrotic syndrome causes renal vein thrombosis. तो हो गया ना? Renal vein thrombosis होता है. Thrombosis क्यों होता है? Why does it happen in nephrotic syndromes? वो तो पढ़ा है, तो आपको भी पढ़ना था. बताओ, why does thrombosis happen in nephrotics? Hypercoagulable state, very good. Why does hypercoagulable state occur? क्यों होती है? आसान काम पहले बताओ ना. क्लॉटिंग करवानी है. क्लॉटिंग करवाने के लिए क्या करना है? क्लॉटिंग फैक्टर बढ़ा दो, एंटी इन्फ्लेमेटरी फैक्टर गायब कर दो बॉडी से. सो एंटीथ्रोमिन 3 गया, प्रोटीन सी गया, प्रोटीन एस गया, सबकी डेफिशिएंसी कर दी. बचाने वाले हैं नहीं, और तंग करने वाले जमा हो गए. तंग करने वाले कौन से हैं? 1 7 8 10, याद रखो, इससे बड़ा अच्छा याद हो जाता है. 1 7 8 10, ठीक है, ये बढ़ जाते हैं. सो दिस इज why complications occur. So many times the presentation of nephrotic syndrome can be related to thrombosis. Could it be DVT? Could be renal vein thrombosis? Could be pulmonary embolism. Renal vein thrombosis means flank pain, hematuria, proteinuria. Pulmonary embolism तो सबको पता ही है, deep venous का भी पता ही है. Now the next question: what etiologies are more synonymous with embolism? Membranous. दूसरा भी बोल सकते हो. Very good. मेम्ब्रेनो प्रोलिफरेटिव में भी हो जाता है, मिनिमल चेंज में भी हो जाता है, एमिलॉइड में भी हो जाता है, राइट. सो इनमें क्या कॉमन हो गया? दे कॉज वेरी सीवियर हाइपोएल्बुमिनेमिया. और कब होना शुरू हो जाता है? क्या टिपिकल एसोसिएशन है? वेरी गुड. लेस देन 2.5 से गड़बड़ शुरू हो जाती है, आपको चकन्ने होना है. लेस देन 2 पे तो बिल्कुल कमर कस लेनी है. ऑलराइट, सो दैट्स वेरी वेरी इंपॉर्टेंट. जिनमें होता है मेम्ब्रेनस तो प्रेजेंट ही ऐसे करता है सीधा. पल्मोनरी एम्बोलिज्म, रीनल वेन थ्रोम्बोसिस. क्लियर? पीछे मैडम, अदर कॉम्प्लिकेशंस ऑफ नेफ्रोटिक. we've talked about the presentation of edema and all those things, but then the complications are different. One is, as he has rightly pointed out, thromboembolism. What else? That's a part of nephrotic syndrome. So that is, we can have more discussion around that, but then that's part and parcel of a nephrotic syndrome. Because we're not saying nephrotic range proteinuria. That's different. We are saying nephrotic syndrome, which means it's what he had referred to as 5 cardinal features. Anything else? Infections. Okay. Now let's talk about infection. Why do infections happen? Very good. What else? Sorry?
Propendrin and factor B.
Good. What else? Then what will happen? No. Predisposition to spontaneous bacterial peritonitis. 4. Breach in continuity of skin. Itni stretching of skin, direct entry of this thing, right? What else? They're on immunosuppressants after the diagnosis. बीमारी ठीक हुई नहीं, सोने पे सुहागा हो गया, ऊपर से आपने कुछ अपना भी कंट्रीब्यूशन कर दिया, ठीक है? All these things. zymogens सारे लॉस हो रहे हैं, सारे प्रोटीन पाथवे का इम्यूनोग्लोबुलिन सारे निकल गए, so all this thing. जिंक निकल जाता है, जिंक बाइंडिंग प्रोटीन नहीं है, जिंक निकल जाएगा तो आपकी इम्यूनिटी कम हो रही है, ऑल दिस थिंग्स. ओके, नेक्स्ट, व्हाट अदर कॉम्प्लिकेशंस कैन यू थिंक ऑफ इन नेफ्रोटिक सिंड्रोम? देखो, द होल आइडिया ऑफ अनाउंसिंग, आई मीन, कि आज केस नेफ्रोटिक का है, तो इतना अच्छा हो जाना चाहिए आपको कि कम से कम नेफ्रोटिक तो ना पढ़ना पड़े दोबारा किताब से, तो तभी होएगा. नेफ्रोटिक तो पढ़ के आना पड़ेगा भाई इसको, मतलब जो चीज़ डिस्कस हो रही है कम से कम उसको तो पढ़ के आओ ना. होल आइडिया ऑफ डिस्कसिंग. तो ठीक है, कई जने पढ़ते नहीं, मेरे जैसे बंदे वो लेट, पता नहीं, प्रोक्रेस्टिनेशन, एंड देन वो डायबिटिक किडनी डिजीज कैसे पढ़ लिया, तैयारी है डायबिटीज़ की कर ली है, तो आपको आप बच गए कि आप डायबिटीज़ नहीं पूछ रहा मैं आज. बट बताओ जी नेक्स्ट, और कॉम्प्लिकेशन कोई? हाँ, राइट. तो जो बाइंडिंग प्रोटीन्स निकली हैं, थायराइड बाइंडिंग प्रोटीन निकली, सो ये सारी वो कॉम्प्लिकेशंस आ गई, ठीक है?
You mentioned malnutrition.
मैलन्यूट्रिशन. पर जो मैं सुनना चाहता हूँ कोई बोल ही नहीं रहा. वो बोलो भाई, क्या दो. सो AKI, नाउ टेल मी, व्हाई डज AKI हैपन? यूज ऑफ डायरेक्ट. बीमारी ने कुछ नहीं किया, जो किया डॉक्टर ने किया. डॉक्टर साहब हम तो ठीक ठाक गए थे आपके पास, आपने कोई दवाई दे दी, पता नहीं क्यों उससे किडनी खराब कर दी हमारी. ऐसे नहीं भाई, ये तो गलत बात है. मैं देखो, मैं डेविडसन पूछ रहा हूँ, मैं तो हैरिसन पे भी नहीं पहुंचा हूँ. फी हाली तो रो रहा है बेचारा, मेरा नंबर ही नहीं आया, मैं क्या करूँ? तो डेविडसन हो रहा है, कौन सा फेक किया है इन नेफ्रोटिक सिंड्रोम, और आउट ऑफ कोर्स भी नहीं है, अनाउंस होने के बाद पूछा जा रहा है सवाल. सो AKI in nephrotic syndrome is a chapter in itself. क्या होएगा कि इतना ज़्यादा निकल गया कि इफेक्टिव सर्कुलेटरी वॉल्यूम कम हो गया, प्री रीनल स्टेट, दैट इज़ 1. दूसरा, पोर्स ही उसके बंद हो गए प्रोटीन से, 2. तीसरा, सेप्सिस. चौथा, डायूरेटिक्स, रीनल वेन थ्रोम्बोसिस. ऑलराइट, सॉरी,
Transformation of glomerular disease to other side.
नहीं, ट्रांसफॉर्मेशन किस में होगी? क्रिसेंटिक, सुपरएडेड क्रिसेंटिक.
First class switch or maybe eccentric transformation.
बट दैट्स नॉट AKI. फिर वो आरपीजन बोल रहे हैं ना क्रिसेंटिक. AKI के तो यही कारण है ना, ठीक है? सो हाइपोवोलीमिया, इंटरस्टिशियल एडीमा. तो रिमेंबर, इंटरस्टिशियल एडीमा, पोर साइज बंद है पूरी तरह से, disruption, use of NSAIDs, बड़ा ही common cause है. NSAIDs is with because normally ऐसे बदनाम किया हुआ NSAIDs को, इतने बुरे नहीं है, but it's only situations like this when body was vulnerable, तब आपने दे दिया. So must remember, AKI गलत बात है, भूल नहीं सकते आप लोग, ठीक है. So these are the complications. Now we will talk about membranous है, the pathogenesis of membranous. Let's say, okay, you've talked about FSGS, an idiopathic FSGS. Why does it happen?
There is no proven no proven link, but there are many circulating permeability factors like supracardiotropin like factor and CD80, which increase the permeability at the slit diaphragm to the filtering of proteins. And there are also genetic forms in which there are mutations in the slit diaphragm proteins as well.
अब आप 29 में आप कौन से congenital की बात कर रहे हो? In your 29-year-old FSGS?
This lady I was like primary only.
Only primary? Can this lady have Alport syndrome?
Yes.
हो सकता है. So फिर तो secondary बन गया. हो सकता है ना.
Presentation is not.
ऐसा ही होता है, कभी मिस ना करना. लेडीज में खास करके रीनल फेलियर नहीं होता, नेफ्रोटिक सिंड्रोम हो सकता है. दिस इज द प्रोटेक्शन विच दे गेट इन द केस ऑफ एल्पर्ट्स. एल्पर्ट भी क्षेत्रा का है, सारे एक्स लिंक नहीं है, ठीक है. सो नथिंग, आई वोंट बी सरप्राइज दैट सच अ केस is indeed a case of Alport syndrome. ठीक है, आपको देखना पड़ेगा. आईज में कुछ नहीं होएगा, ईयर में कुछ नहीं होएगा, बिकॉज आपने देखा ही नहीं, मिला नहीं. देखा तो सब कुछ मिल जाएगा, राइट. आपने सर्कुलेटरी के बोला, सो यू सेड देयर इज अ कंट्रोवर्शियल रोग. सुपार ने सुपारी दी कि नहीं दी? दी सुपारी. तो क्या क्या एविडेंस है कि सुपार ने सुपारी दी? कैसे पता लगा कि सर्कुलेटिंग है? पहले बहुत शोर मच रहा था, अब सडनली आपने कह दिया कि नहीं है, नहीं है. तो कुछ एक्सपेरिमेंटल, कुछ दिमाग लगाओ कि EFSCS हुआ, इसमें सर्कुलेटिंग इवेंट्स है, इस बंदे की किडनी किसी दूसरे नॉर्मल बंदे के में किडनी में लगा दी, क्या होएगा? रिकरेंस नहीं होगा, क्योंकि उसमें है ही नहीं है. रिसिपिएंट में तो सुपारी है ही नहीं, सुपार है ही नहीं, ठीक है. एक कैडेवरी किडनी ली, नेफ्रोटिक स्टेट था, पता ही नहीं लगा, थोड़ी सी प्रोटीन था, उसकी किडनी लगा दी, बेंच पे बायोप्सी कर ली, बाद में आ गया FSGS, तो डर गए सारे जाने. लेकिन उधर जाके पता लगा कि वो तो अच्छी भली चल रही है, तो लो प्रोटीन यूरिया. दैट मीन्स देयर वाज सम सर्कुलेटरी, ठीक है. आप प्लाज्मा एक्सचेंज करते हो तो कैसे फायदा हो जाता है उसका? तो ऑब्वियसली यू आर रिमूविंग समथिंग. सो ये चीज़ें सोचो ना, क्यूरियोसिटी यही तो है. व्हाई डज प्लाज्मा एक्सचेंज हेल्प? कुछ तो होगा. पोस्ट ट्रांसप्लांट FSGS में, रिकरेंस में आप प्लाज्मा करते हो, ठीक है ना, कुछ तो निकालते ही हो ना. और प्लाज्मा क्या करता है? इट विल रिमूव समथिंग व्हिच इज अनवांटेड. ओके, मेम्ब्रेनस कैसे करता है? मेम्ब्रेनस की सिद्धेश, हाउ डज मेम्ब्रेनस हेल्प हैपन? Pathogenesis of membranous nephropathy. Yes, so all these are podocytopathies. Minimal chain disease, FSGS, membranous nephropathy, which altered the cytoskeleton, even in FSGS, even the congenital varieties. There's a congenital nephrotic syndrome. वो शुरू से एक्टिन वाला जो होते हैं, उसका cytoskeleton खराब हो जाता है. Terrible. But podocytopathy is fine. Why does it happen? There was an entity called Hayman's nephritis. We knew कुछ है गड़बड़, तो समझ नहीं आ रही थी क्या है, till the time we finally came across PLA2R. So which means, how can it happen? In membranous, remember, membranous could be in three varieties. ये पोडोसाइट इसको डिस्ट्रॉय करना है, यहाँ लड़ाई हुई आपस में, वो ल्यूपस में सर्कुलेटरिंग, राइट, आपस में लड़ाई करते 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 चिपक गए यहाँ पे, उसको डिस्ट्रॉय कर दिया। बेचारे का कोई कसूर नहीं है, बेगाने की शादी में ये बेचारा दूल्हा गया बेचारा, राइट। नंबर टू, this is an antigen against which PLA2R, so M type phospholipase receptor आके इसको पकड़ लिया and इसको destroy कर दिया। That's 70% of your cases. So basically यहाँ एंटीजन इम्प्लांटेबल एंटीजन यहाँ था और उसके ऊपर एंटीबॉडी लग गई तो डिस्ट्रॉय हो गया। तीसरा एक और है, कोई बताएगा? वाइन तो सारे PLA2R वही हो गए ना, उसी में ही हो गए सारे। वो तो आपने थ्रोम्बोस्पोंडिन बोल दिया, सारे एंटीजन उसमें लगे हुए हैं, उसमें नहीं है। अब इटियोलॉजी समझो, पहले मैं कह रहा था कि ये यहाँ पे कुछ नहीं है, कोई लड़ाई दूसरी होती 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 आके कोलेट्रल डैमेज कर गई, उसको बेचारे को पकड़ लिया, इसके बेचारे को भी कसूर नहीं था। दूसरा ये कसूर ये था, इनोसेंटली बैठा हुआ था कि बॉडी में PLA2R आ गए, थ्रोम्बोस्पोंडिन आ गए, किटाइन बोवाइनिक आ गए, नेल आ गए, सिमाफोरिन आ गए, जो सब आ गए तो डिस्ट्रॉय कर दिया। तीसरा, पॉम्पेज डिजीज में क्या होता है, फिर पता लगेगा पॉम्पेज डिजीज में, ठीक है। यहाँ आपने जो ये दिए ना, ये शायद पेमिट्रोनेट वगैरह नहीं है, वो तो FSCS में चले जाएंगे। कुछ चीज़ें व्हाट दे डू इज, कुछ एंटीबॉडीज थी यहाँ, ये जो VEGF वगैरह, ये जो दूसरे जो बेबसिजुमैब जो लगाते हो, दूसरी चीज़ें जो इतने सारे आप पढ़, तो उनमें एंटीबॉडीज होती है। वो इसके ऊपर एक एंटीबॉडी रहती है, ये तो अच्छा भला है, इसके ऊपर कुछ लग गया, उसको आगे उसने पकड़ लिया। थर्ड is a different variety that's not against the podocyte cytoskeleton, इसके ऊपर कुछ लगा और उसको आके उन्होंने पकड़ लिया। These are the sort of the basics where you will get membranous. तीसरा बताया आपने, ल्यूपस हम बात नहीं करेंगे, ल्यूपस तो समुंदर है, कहाँ डूबेंगे उसमें। You said IgA. How often do you get nephrotic syndrome in IgA nephropathy?
5% of overall presentation of IgA can have nephrotic.
Right. But looking at the incidence and prevalence of IgA nephropathy in our population, look at what 5% can mean. So, out of all the glomerular diseases, how often is IgA nephropathy? Is the commonest variety, right? Not nephrotic syndromes, but any proteinuria, subnephrotic, mild, moderate, severe, IgA nephropathy is the commonest cause. Good 30 to 35% will have IgA nephropathy. Out of these 30-35%, even if 5% were to have nephrotic range proteinuria, look at the incidence, ठीक है ना? So that's why IgA is important. और हम आगे बढ़ते जाएंगे जितना टाइम परमिट करेगा, and whatever we can cover in nephrotic syndrome, you must say.
Just to reframe what I was saying in the beginning,
Yeah.
like if somebody asks you a pure question, what are the causes of nephrotic syndrome? You should be in a second, like Dr. Kuller was saying, these are the causes: FSGS, minimal membranous diabetes, lupus, myeloma, amyloid. This list should be very clear in your mind. And then the list of nephritic, nephrotic. Those two lists should come to your mind right away. I'm not saying what you said was wrong. All I'm saying is you have offered a bit extra information right in the beginning. And like if you look from an exam point of view, you may not even proceed on to the later part of your presentation because you'll be kept, you'll be entangled in the web of differentials like that. So you make sure your list is very clear. What are the causes of nephrotic, nephritic, nephrotic, and then which out of those are applicable to my patient. So before you say anything, you should know like why are you saying this. Again, you've probably put across like if you were talking about a pure nephrotic syndrome, I would rather like to hear membranous, lupus, FSGS, those. Why not minimal change? The age is a bit, off the normal presentation. So you need to be very clear. Okay, these are the causes for pure nephrotic, pure nephritic. Like you offered extra information out of after your physical exam. This was what I saw in my urine exam, urinalysis. So that should take out some things out of your list. Why this is not nephritic with nephrotic? Why do you think this is more like nephrotic only? So this list basically like sir, you should be clear with the causes in your mind and then be able to defend yourself. Why have I put these diagnoses in the first line?
Anurag, going by the causes, what are the secondary causes of FSGS? Shiva, which one? काफी है, इतना तो मेरे को नहीं आता. सो जहां पे भी नेफ्रॉन मास कम हुआ, सॉलिटरी किडनी, morbid obesity, right? Sickle cell anemia, reflux nephropathy, nephron, they ask up, oligo, नहीं, what is that called? Dysgenesis, right? So dysgenesis में उसका क्या नाम होता है जो छोटी, yeah, so wherever there is hyperfiltration which will cause FSGS, hemidronate, interferon, कैसे करते हैं, क्या मैकेनिज्म है, उसको सारी चीज़ें क्लैरिटी रखो भी. कौन सी malignancies है? Right. हाँ, कौन सी वाली? कोई लिम्फोमास करते हैं, कौन सी वाली? सॉलिड ऑर्गन malignancy आप सीधा मेम्ब्रेनस की तरफ चले जाते हो. malignancies आर मोर कॉमन. आई एम नॉट सेइंग बाकियों से नहीं होती, तो एमपीजीएन पैटर्न में भी malignancies है पूरे, आपको पता ही है सारे, एमजीआरएस भी और दूसरे malignancies भी है. देन मिनिमल चेंज है तो हॉजकिन लिम्फोमा है, नॉन हॉजकिन लिम्फोमा है, और फ्यू अदर ऑर्गन, सॉलिड ऑर्गन malignancies. सॉलिड ऑर्गन मेम्ब्रेनस है तो उसमें तो दुनिया भर के सारे आ जाते हैं एफएसजीएस में. देन जो सार्कोइड अगर प्रेजेंट करना उसमें, ठीक है. और तो ये तो रटे होने चाहिए कॉजेज ऑफ नेफ्रोटिक. अरे नेफ्रोलॉजिस्ट को नेफ्रोटिक नहीं आना तो किसको आना है?
And then, sir, I think FSGS per se, you mentioned the drugs, infection, compensatory hypertrophy. Outside that, for FSGS, you also must say this could be a progressive histological change seen as a part of the progression of primary disease. In your practice, you'll encounter a lot of cases where you are suspecting hypertension or some other cause, and you're seeing the FSGS pattern. And the presentation might be a mix of primary nephrotic syndrome versus there's something else going on, and then to treat or not to treat with immunosuppression, because differentiation between primary and secondary, why is it most important? Because the treatment is very different. For primary, you're going to subject them to immunosuppression right away. So in your clinical practice, often you'll have to see like where does the patient fit in, and sometimes there's an overlap in the presentation also. So for FSGS per se, you have to also remember it could be a part of just the histological changes that you are seeing in the progression, or like the progression of the primary problem.
वो
Or
हर एक में होगा. नो डिजीज कैन सडनली jump from here to there. It has to be hypertension with secondary FSGS. आपकी typical reports क्या आती है? Hypertension with secondary FSGS. Why? Because आज hypertension था, उसमें थोड़ा सा खराब हुई, थोड़ी और खराब हुई, थोड़ी और खराब हुई, और पूरी खराब हो गई, global sclerosis. IgA nephropathy with secondary FSCS, diabetes with secondary FSCS. So any disease जब वो nephrons को खत्म करेगी तो the remnant ones, Brenner's hypothesis, the others will have to hypertrophy, hyperfiltrate, and eventually fail, right? So it's a spectrum from a normal to less normal to partially destroyed to totally destroyed, and partially destroyed is FSGS kind of pattern, right?
Whatever we are talking as nephrologists, this just not just reading the pathology report. Why is it important understanding the renal pathology from inside, or what changes do you see in different diseases, or what is the zebra hair, or how can it present differently? You should always read the full report, see what was the clinical picture, and don't just go by the last statement saying, okay, this was seen. This is just the bottom line that the pathologist has seen. But ultimately, the onus is on us who are evaluating the patient clinically. You need to know what was the clinical presentation. Does the pathological pattern even fit in there or not? Like, you have all the clinical details. What is the progression of the patient? How was the presentation? What were the secondary causes I could find or I could think of? And then correlate with that. Don't just go by the biopsy report. And that will come only when you have the understanding of what actually the patterns you can see in different diseases. That is the reason we are sitting, discussing in detail what is this pattern, what is that pattern. You might just say, why do I care? I get a biopsy report from the pathologist. No, no matter, where whoever is reading the biopsy, that's a useful adjunctive tool. But still, it's your clinical decision making at the end that will create a huge difference in a lot of cases. You have to keep thinking, okay, this was the pattern, and like so many times after the report, at least I have to go back to the patient or their labs and see, did I miss something? Oh, this was found. So again, you have to correlate.
Yeah.
Sometimes you have to go back and see, okay, this is what I should do.
Now moving on, how will you proceed in this case? What all investigations? You've done only the routine urine analysis. What further investigations are you going to ask in this patient?
Hemogram, renal function test, then albumin, lipid profile,
Albumin, lipid profile.
then for rollout secondary.
नहीं, serum protein भी कराओगे, सिर्फ albumin क्यों कराओगे?
Yes.
How will that help you?
Albumin too.
आप कहोगे nephrotic syndrome means hypoalbuminemia. मैं प्रोटीन क्यों कराऊं भाई? मेरे को क्या जरूरत है? मेरा डायग्नोसिस बन जाएगा एल्ब्यूमिन से.
To see the status how liver is compensating.
Why liver? मैं तो कुछ और सोच रहा हूँ. मेरा एल्ब्यूमिन कम है, 2.5 है, बट प्रोटीन तो 8 है. अच्छा वाला तो है, ठीक तो है. प्रोटीन 8 है, एल्ब्यूमिन 2.5 है. What is this diagnosis?
Then non-albumin proteins are leaking.
आगे किस में हो गया ये? किस में? माइलोमा, बस
Chronic
माइलोमा,
inflammation, cirrhosis.
हाँ, इन्फेक्शन हो गया. माइलोमा प्लाज्मा सेल में एक में लाइन में लगा दिया. और अरे ऐसे ना करो भाई.
Liver
एजी रेशियो किस में अल्टर होती है? लिवर
liver cirrhosis,
और
HIV and other chronic infections.
क्रॉनिक इन्फेक्शन में क्यों होगा? प्रोटीन भी कम हो जाएगी या ग्लोबुलिन्स चलो बढ़ जाएंगे, ग्लोबुलिन्स बढ़ जाएंगे. और ल्यूपस, ठीक है. So remember, these are the things which come to mind. So प्रोटीन भी मांगूंगा मैं, अकेला एल्ब्यूमिन नहीं. और else इसके बाद
Urine protein quantification, urine protein create ratio.
very good.
And
Urine protein creatinine ratio he is asking for. Is that enough? What is nephrotic syndrome? Proteinuria more than 3.5 grams per 24 hours, or spot urine protein creatinine ratio of more than 3, right? That's protein creatinine ratio. Are you happy with that? जैसे मैंने अभी पूछा, मैं प्रोटीन भी चाहूँगा. So urine protein creatinine ratio के साथ मैं कुछ और भी चाहूँगा. मैं क्या चाहूँगा? मैं एल्ब्यूमिन क्रिएटिन रेशियो भी चाहूँगा. व्हाई वुड आई वांट अ क्रिएटिन? हो तो गया प्रोटीन, डायग्नोसिस बन गया, प्रोटीन मोर देन 3.5 grams, रेशियो मोर देन 3. व्हाई should I want albumin urea?
Mismatch between these two can predict plasma cell distress. Yeah.
आप लोगों का ईयर कौन सा है? ईयर थर्ड ईयर, फर्स्ट, ठीक है. अगली बारी मैं नेक्स्ट पूछूंगा, ठीक है, याद रखूंगा. सेकंड तो मिक्स है. ओके, व्हाट इज थर्ड ईयर सिलेक्टिव प्रोटीन यूरिया? मैं वो पूछा ही नहीं, मैंने तो पूछा व्हाट डू यू मीन बाय selective protein urea? Why does that happen? No, मैंने पूछा ही नहीं, मैंने सिर्फ अभी पहला सवाल पूछा, सिलेक्टिव क्या होता है? बता दिया आपने, ठीक बताया, ठीक है. सो क्या होता है सिलेक्टिव? नॉर्मली ये हमारा वो बेचारा परेशान है, यहाँ से एल्ब्यूमिन जाने लगा और इसको करंट लगा, so negative repels each other, both are negatively charged, so this repels the albumin and albumin is not able to go that side. Supposing this charge goes away, all right, and whatever was constituting this negative charge has been destroyed, there is a cytoskeleton disruption, podocytopathy, this charge is gone. Now albumin can go the other side because the negative charge is gone. Still remember, that's the most important concept, size बड़ा नहीं हुआ, size barrier is still there, the charge selectivity has gone, so only albumin will pass. Albumin 69,000. IgG थोड़ा सा बढ़ा दो. IgM कम कर दिया तुमने तो. $69,000 albumin, 1,60,70,000 IgG, 9 lakh IgM, 9 लाख बहुत बड़ा होता है, शुरू में तो ही बनता है, राइट. सो जब बहुत बड़ा हो जाएगा तो सब कुछ ले जाओ बाहर. So there's a difference between charge selectiveness and the size selective barrier. जब पूरी धज्जियां उड़ गई उसकी, तो that is why अगर किसी ने छोटा सा छेद किया है, उसमें से सिर्फ एल्ब्यूमिन निकलेगा अपने नेगेटिव चार्ज खत्म होने की वजह से, साइज की वजह से नहीं. जब साइज खुल गया तो एल्ब्यूमिन भी निकलेगा और बाकी भी निकल जाएंगे. आप प्रूव कैसे करोगे?
Difference between these two.
इतना आसान भी नहीं है सवाल. सो एल्ब्यूमिन निकल रहा है लेकिन IgG नहीं निकल रहा है, तो उसकी रेशियो देख लो. तो एल्ब्यूमिन ना देखो, ट्रांसफेरिन की रेशियो IgG के साथ देख लो, ठीक है. 0.1 से ज़्यादा है कि 0.1 से कम है, वो पर ज़्यादा पता लग जाता है कि कौन सा प्रोटीन यूरिया. क्लियर होगी बात? साइज सेलेक्टिविटी एंड चार्ज सेलेक्टिवनेस इज एक्सट्रीमली इंपॉर्टेंट. और जब साइज बैरियर ही चला गया तो दिस मीन्स कि हो गया कल्याण, ठीक है जी. इसीलिए चार्ज तो वापस ले आते हो, एल्ब्यूमिन जब निकल रहा होता है तो आप स्टीरॉयड दे दो के उसको ठीक कर लेते हो, तो जब बेचारे की धज्जियाँ उड़ जाती हैं कुछ नहीं होता, ठीक है. क्लियर दिस कॉन्सेप्ट ऑफ. अब आपने ऑर्डर कर दिया एल्ब्यूमिन. दूसरी चीज़ जो एल्ब्यूमिन की जो आपको बतानी चाहिए थी, व्हेन इट इज यूरिन प्रोटीन क्रिएटिन रेशियो, ठीक है, तो ये तो मल्टीपल माइलोमा में हो जाएगा, वो तो दूसरी तरह की प्रोटीन से पकड़ लेगा. ये प्रोटीन तो प्रोटीन है. वाइल एल्ब्यूमिन यूरिया मींस ओनली जो डिपस्टिक्स में आता है, डिपस्टिक में एल्ब्यूमिन आता है, तो अगर उसमें प्रोटीन नहीं है तो यू विल से नो एल्ब्यूमिन यूरिया, लेकिन जब 24 आवर्स वाला कराओगे तो उसमें आ जाएगा प्रोटीन ही प्रोटीन। तो ये होते हैं दूसरे वाले प्रोटीन, ठीक है, कौन से, डेंस जोन्स प्रोटीन। तो अब मेरा सवाल ये है कि प्रोटीन यूरिया कैसे होता है? 3 तरह का होता है। कैसे? ग्लोमेरुलर, ट्यूबुलर, ओवरफ्लो होता है। ग्लोमेरुलर, अब इसी को घूम फिर के हम बात कर रहे हैं एल्ब्यूमिन, ठीक है। ट्यूबुलर डेंस जोन्स टाइप्स, नहीं जो बीटा 2 माइक्रोग्लोबुलिन नहीं, जो एंड ओवरफ्लो लाइट चेन्स। ओके, आगे बताओ क्या करोगे?
To rule out lupus and membranous, so anti PLA2R antibodies and complements level and ANA.
ठीक है, चलते जाओ।
Viral markers hepatitis B and hepatitis C, and then coagulation to proceed for kidney biopsy.
आप हर एक की किडनी बायोप्सी कर दोगे?
If
आपने PLA2R नहीं भेजा?
बोला सर,
भेज दिया ना, वो रिपोर्ट आ गई अगले दिन पॉजिटिव, करोगे बायोप्सी? अभी तो आपने तैयारी कर ली पूरी।
depends on kidney function.
सो कौन सी कंडीशन है जिसमें बायोप्सी नहीं करोगे? है ऐसा कोई चक्कर कि मेम्ब्रेनस में नहीं करोगे और यहाँ कर दोगे कुछ?
Normal kidney function with anti-PLA2R positive with titer of more than 14 or by
14 तो नेफ्रोटिक सिंड्रोम का डायग्नोसिस बन जाएगा ना। But और बड़ी चीज़ें होती हैं उसमें, या तो आप कह दो कि 60 से ऊपर है, 60 से ऊपर है तो स्पॉन्टेनियस रिमिशन नहीं होती है उसमें, ठीक है। 14 to 60 के बीच में तो आप ना करो बायोप्सी, फिर कुछ भी ना करो, उससे तो अपने आप ठीक हो जाएगा, ठीक है ना। उसकी धार देखो किस तरफ जा रहा है। बट इट्स कॉन्ट्रोवर्शियल, डोंट बी हैविंग फिक्स्ड आइडियाज़ कि हमने PLA2R पॉजिटिव आ गया है, हमने बायोप्सी नहीं करनी है, ऐसा नहीं है। तो यू हो सकता है जब तक इवॉल्व नहीं कर जाती हैं, इंडिकेशंस बेटर नहीं हो जाती है, तो नहीं करोगे, ठीक है। सो ये बात अगर उठी है, यू रीड KD को गाइडलाइंस जो नया आया हुआ है, PLA2R इट मे नॉट बी रिक्वायर्ड, और जैसे जैसे डाटा आ जाएगा दी अदर साइड, आई मीन आप कहोगे मैं करना चाहता हूँ, मैं कहूँगा नहीं, आई विल बी एबल टू डिफेंड माई सेल्फ दैट मैंने GFR कर ली उसकी, मैंने उसकी अच्छे तरीके से GFR कर ली, डजेंट मैटर, सिर्फ प्रोटीन यूरिया है, एब्सोल्युटली नॉर्मल GFR, मैं क्यों करूँ बायोप्सी, ठीक है। आप जो कह रहे हो, बट व्हाट एडिशनल इन्फॉर्मेशन डू वी गेट इन टर्म्स ऑफ थेरेप्यूटिक्स? PLA2R पॉजिटिविटी है, you've given rituximab, now you wait after at the end of 6 months, वो भी KD को गाइडलाइंस में लिखा हुआ है, wait for 6 months, at the end of 6 months 3 things can happen, it's all gone, it's all gone, चुप बैठ जाओ, it is still present, it is present but less than the original, it is present increasing, it is, so जिसमें बढ़ रहा है उसमें तो आप ट्रीटमेंट चेंज कर दोगे, पॉन्टिचेली में चले जाओगे और CNI पे चले जाओगे। जिसने नेगेटिव था इनिशियली एंड नाउ इट्स बिकम पॉजिटिव, अब फिर उसको रिटुक्सिमैब दोगे, ठीक है। सो एनीवे लेट्स नॉट गो इनटू द थेरेप्यूटिक्स, टॉकिंग अबाउट जितना हम कर पाएंगे आज वो है द मैनेजमेंट ऑफ एनी नेफ्रोटिक, बताइए।
So for management for nephrotic syndrome, first you have to see for sodium restriction less than 2 gram per day, then blood
कितना
pressure and
प्रोटीन रिस्ट्रिक्शन, नहीं आपने क्या बोला?
सोडियम कह रहे
sodium
हैं,
सोडियम
सोडियम लेस देन 2,
लेस देन
2 gram per day.
सोडियम 2 ग्राम पर डे या सॉल्ट?
Salt
सॉल्ट कितना?
2 gram per day.
सोडियम या सोडियम क्लोराइड? पता है, कंफ्यूजन है इसमें, पता है कुछ? ठीक है, अब आगे चलो।
For proteinuria, F inhibitors or ARB.
ना डाइट पूरी करो भाई, नमक तो आपने बंद करा दिया, बाकी
Low
उसको रोटी
protein in the form of 0.6 to 0.8 gram per kg per day plus urine loss.
ये कहाँ से पढ़ा है? ये गलत स्टेटमेंट हो गया। प्रोटीन रिस्ट्रिक्ट करोगे, नेफ्रोटिक सिंड्रोम है।
No, sir, but they have given 0.8 to 1 gram per kg.
अब बढ़ गया ना, अभी तो 0.6 to 0.8 बोल रहे थे, बहुत फर्क है।
0.8 to 1 gram per kg per day plus urine loss up to 5 gram.
ठीक है,
Diet
अगर GFR कम हो गया तो
0.6 to 0.8 but not below 0.6.
ठीक है जी, वेरी गुड। सो अगर GFR कम है तो, बट मैल न्यूट्रिशन नहीं होने देनी है
And
इनको,
for
अच्छे से करो।
hyperlipidemia, fat content should be less than 30% of all total calories, and unsaturated fat 7 to 10%. Calories 35 kilocalories per kg per day, and if GFR less than 60, then 30 to 35 kilocalories per kg per day.
ठीक है,
And
नेक्स्ट लाइन ऑफ मैनेजमेंट डाइट हो गई, उसके बाद
for proteinuria reduction, ACE inhibitors or angiotensin receptor blockers to maximum tolerated dose, and for blood pressure to less than 120 by 80.
वेरी गुड। इन ऑल द केसेस सब में ये कर दोगे। अगले दिन बायोप्सी की रिपोर्ट आ गई है मिनिमल चेन डिजीज, आप एस इनहिबिटर दोगे? है कुछ तुकबंदी कुछ? अब बता, ये तो केडी को भी नहीं बोलता, केडी को ने भी लिखा हुआ है कि इफ यू आर एक्सपेक्टिंग a rapid resolution of the proteinuria, you don't have to give ACE inhibitor. So FSGS में yes, IgA nephropathy में yes, but membranous nephropathy, if it is subnephrotic, yes, but if it is a frank nephrotic state like minimal chain disease and you are expecting a quick resolution, you may even wait. और minimal chain disease में तो जब पता है कि एक महीने में ठीक हो जाना है तो RAS, and the same holds true for lipid lowering agents. जब पता है कि एक महीने के अंदर ठीक हो जाना है, then you may not want to go in for any unwanted toxicity of any drug. ठीक है ना? What next? How will you treat? Now let's read the biopsy report.
So in light microscopy, there is 10 glomeruli. None was sclerosed, mild muscular expansion. No membrane thickening, no sclerosis, no endocapillary proliferation or crescent. Tubulointerstitial compartment normal, and vascular compartment is also normal. In immunofluorescence, this IgA 3 plus granular in mesangium and capillary loops, IgM 1 plus, kappa 1 plus, lambda 3 plus.
And how much was the proteinuria quantification?
So 4 grams.
4 grams. So you are now having a patient of nephrotic syndrome, biopsy showing IgA dominant nephrotic state, minimal chain disease, right? Minimal chain disease on light microscopy. On immunofluorescence, it is IgA. Electron microscopy report is awaited. What do you expect to see on electron microscope?
Diffuse food process assessment.
Yes,
More than
so it will
80%.
not be the usual IgA nephropathy, it will be podocytopathy, and this is the case we were referring to, that they will respond to steroids, and you should treat these kind of nephrotics where there is an IgA nephropathy, light microscopy, minimal chain disease. So these were the cases in the absence of routine availability of immunofluorescence till a couple of decades ago were always labeled as minimal chain disease. They would respond also to steroids, and we always thought that IgA nephropathy is not that common in India till the time we started doing it more commonly. So this is what it means. If 5% of IgA nephropathy can present as nephrotic syndrome, so it doesn't come as a surprise that the only surprise is why were there no RBCs in the urine. So that is something one has to carefully look at. All right. I'm not saying it cannot happen. These kind of podocytopathies where there are just incidental deposits of IgA may not have RBCs.
So can it be explained by normal light microscopy because there is no damage as such in the
Yeah,
form
so
of
they are, I'll say they're incidental, coincidental IgA. So they are dominant but coincidental IgA deposits in the this thing. No,
IgA with
there is a
podocytes?
special subcategory of IgA presenting as nephrotic syndrome and minimal chain disease. What are the secondary causes of IgA nephropathy? आप बताओ. कौन सी malignant? ऐसे IgA vasculitis, IgRN, IgRN, ठीक है, IG immune globulin infection related this. So IgAV celiac हो गया, inflammatory bowel
CLD हो गया.
CLD हो गया. So these are the secondary causes of IgA.
CLD में क्यों होता है IgA deposition?
Decreased hepatic clearance of immune complex.
By Kupffer cells.
कौन सा होते हैं? मोनोमेरिक मेरिक होते हैं, पॉलीमेरिक होते हैं. दो तरह के IgA होते हैं, IgA1, IgA2. कौन सा है? सो लिवर उसको स्कैवेंज नहीं कर सकता है, तो इट्स एन एबनॉर्मल है, तो खराब वाला ना ये. और हाउ विल यू ट्रीट this patient? 4-gram proteinuria, 29-year-old lady, nephrotic syndrome.
So first we'll wait for EM report, and if it is showing MCD like pictures, then it
You will not wait. We already waited for 6 months. We already waited for 6 months.
So
Regardless,
we can
yes, at this stage. Why? Regardless, कुछ भी निकल आए. It is IgA nephropathy presenting as nephrotic syndrome. It is minimal chain disease with incidental IgA deposits. The treatment will be steroids because the proteinuria is 4 grams and it is symptomatic now. If she was compensating well, serum albumin was more than 3.5, there was no edema, no pleural effusion, so you could have taken it lightly. Now the disease has started troubling your patient. Now you'll go wholeheartedly after the disease, right? So steroids तो देना ही है. कौन से दोगे?
prednisolone 1 milligram per
So there are
kg
two
per day.
different entities, हम IgA and incidental IgA deposit, दो अलग-अलग entities हैं ये. इनका treatment ही अलग है. ठीक है?
Prednisolone 1 milligram per kg per day. So we'll treat as MCD adult, so we'll give and see for proteinuria reduction we can give maximum for 16 weeks, and then we'll see the remission. If she will go in remission, then we'll decrease taper after 2 weeks and complete the steroid course over 4 to 6 months.
Supposing now हम इसको IgA लेबल करते हैं, तो IgA अगर 6 महीने पहले आती तो proteinuria 1 ग्राम से कम होता, you would have given maximally tolerated dose of RAS blockers. Number 2, SGLT2 inhibitors. ठीक है, राइट. so ये तो हमने करना ही है. उसके बाद भी अगर proteinuria बढ़ गया, now if it is IgA, you will see target release budesonide or conventional steroids. ठीक है. Now 6 months you've given this lady, or at the end of 16 weeks, the response is not very great. What would be your next line of management?
Sir, for FCD which is not responding to steroids, so second line treatment recommendation is CNI, cyclosporin or tacrolimus.
Very good.
Or we can consider also if patient is patient preference is there, then we can also offer cyclophosphamide 8 to 12 weeks. But
मिनिमल चेन डिजीज में साइक्लोफॉस्फेट बाद में आएगा. you will first say steroids and then CNIs. For steroid resistant you will say CNIs. For steroid dependent, to break the dependence, you will bring in cyclophosphamide. So that's it. But yes, if CNIs have not helped, then cyclophosphamide. Now the other way around, if it is IgA nephropathy, you've given steroids, target release or conventional, what would be your next line of management?
Try MMF.
Based on which data?
In Chinese main trial.
So the main trial will tell you that you can have some confidence in MMF, 70% response up to, right? Or else enroll your patient in one of the trials. All right, there are various trials. कौन सी है?
BAF and April inhibitors, then spleen tyroskinase inhibitor, postpartum complement inhibitor.
नहीं,
like
sparsentan
avopapan.
बोलो, atrasentan, so endothelin receptor antagonist और ये तो आ गई है ना दवाइयाँ. Sparsentan is the blockbuster हो रहा है. हाँ? Sparsentan, atrasentan, that's one. और कौन सी दवाइयाँ? चलो, let's not go into detail, but you must know जो यूज हो रही हैं. April, yes, pathway inhibitors, complement pathway inhibitors, iptacopan, narsoplimab. Narsoplimab has been called off. It's been a failure of a trial, so it's been retraced. All right, that's the two parallel spectrum चल रहे हैं. All right, meaning IgA nephropathy is a spectrum. Don't confuse the two. वो हो सकता है ये वाला आपका पेशेंट मिनिमल चेन डिजीज है with it's a podocytopathy because आपके उसमें कोई mesangial expansion नहीं है. Light microscopy has not shown any mesangial expansion, so it's all podocytopathy. all right, उसमें आप typically minimal change की तरह ट्रीट करोगे, रिटुक्सिमैब तक पहुंच जाओगे. ठीक है. On the other hand, IgA में you will see whether there is going to be a chronicity or not. What are the chances that this patient will deteriorate? RAS को blockage नहीं ठीक आया, और if it exceeds 1 gram, there is a chronicity, you believe a kidney खराब होने वाली है, based on the MEST score, based on the prediction tools, you will decide the treatment of IgA. Clear?
One other thing you mentioned, cyclophosphamide. If I heard it right, she's just married for 8 months and I didn't have the OBS history. So, like in a young female, before prescribing cyclophosphamide, fertility preservation should always be on your mind. And for somebody like, you mentioned she's a chartered accountant, a well-to-do person, you should offer, gamete preservation. That is very important. And you might want to choose another drug for fertility preservation in this young female.
So it should be the last resort. Cyclophosphamide in a female, अगर कभी ज़रूरत पड़ जाए, then you must know how to protect which day of the cycle. You have to base your cyclophosphamide therapy or GnRH analogs दे के you protect the ovaries first, or egg preservation, and then, but preferably void. That should be the fourth in a female of young reproductive age first. Supposing this lady gets unfortunately does not respond to treatment, goes into a stage of chronicity, requires transplant. What are the chances of recurrence of IgA nephropathy?
Sir, IgA nephropathy recurrence rate is around.
In fact, our discussion today should not be revolving around IgA nephropathy. This is not IgA nephropathy. All right, this is not. This is a nephrotic syndrome. This is. I hope I'm clear. जो हम कह रहे हैं कि IgA nephropathy can cause nephrotic syndrome, उस IgA nephropathy में histopathologically there should be extensive mesangial proliferation. तो जहाँ proliferation ही नहीं है, तो वो प्रोटीन यूरिया कहाँ से कर दिया? So that means it is minimal change disease. Why does minimal chain disease happen? Pathogenesis.
It's damage to podocytes
कैसे होता है?
promoting
अब
split diaphragm.
अब फिहाली को भी तो खुश करना भाई, बहुत डेविडसन हो गई अब फिहाली, हाँ?
Overexpression of CD80 receptors
Very good.
and IL-8, IL-13 polymorphism
Ratio, very good.
and hemopaxin.
वेरी नाइस. सो आपने उस पोडोसाइट की धज्जियाँ उड़ानी है और उसको पूरा नष्ट करके छोड़ना है. नाउ यू फाइंड वेज टू डू दैट. ठीक है. T cell mediated. It's a classical. NSAIDs cause nephrotic syndrome and it's minimal chain disease. It's again T cell mediated, right? और इसके अलावा minimal change हो गया. Complications हमने जो बोली थी spontaneous, we did mention about spontaneous bacterial peritonitis, right? उसमें कौन सा how do you make a diagnosis of SBP? These are questions which are not necessarily from the exam point of view. It's from the practical management from point of view. You must know how to diagnose SBP, what are the common organisms, how do you treat them, how long for, how does it happen. बच्चों में तो बहुत ही common है SBP. So, I think we'll have to end now. Any questions?